He residency at University of Toronto. Dr. Allen's work from 2013 to 2015 with the University of Toronto Counseling and Psychological Services. And he is a consultant at Asia Clinic, at Hong Fook Mental Health Association, and at the ADHD Clinic. Also have private practice. Dr. Albert Allen currently clinical interests are areas of assessment, treatments, and psychopharmacology in the area of attention deficit, hyperactivity disorders, anxiety disorders, and he also has interest in mindfulness-based treatment. Please help me welcome Dr. Albert Allen. And after our training, there will be a survey that will pop up on your screen. Please help us fill that out, and that is very important for our team to understand the process and improve the process in the future. Okay? Okay, let's start. Thank you so much.
Okay, so hello everybody. All right, so I think we have about an hour and a half today, so I'll be speaking about trauma. In terms of what to expect for today, we'll be talking about what are traumatic events, effects of trauma, how people respond to trauma, and how to support somebody who has experienced trauma, as well as treatment from the psychiatric perspective about post-traumatic stress disorder. So I want to make the talk more about trauma in general than specifically about diagnosis and treatment of PTSD, because I think I understand the audience is kind of clinical, but we're not all like medical people. So starting with what are traumatic events. One thing about trauma is trauma is something that requires us to reevaluate our understanding of our lives in the world. So we all have a kind of mental model of how the world works. Generally, for most of us, we have assumptions that the world is generally safe, other people will interact with us fairly, and lives will be more or less predictable. So the kinds of things that cause disruptions to those ways of thinking about the world and our lives are the sorts of things that tend to traumatize people. There's a book by Mark Epstein called Trauma of Everyday Life, where he talks a bit more about this. So you have the kinds of trauma that are like car accidents, being assaulted, witness tragedies, sort of like major traumas, but there's a sort of every aspect of trauma where experience things like death or loss or disappointments, are things that are often outside the scope of what we consider to be normal in our lives, and then we have to find a way to come to terms with that. Sense, the process of dealing with trauma is universal. So I'll be talking a bit more about that as the talk goes on. We're talking about the clinical definition of trauma in terms of what sorts of trauma meet the threshold to diagnose somebody with post-traumatic stress disorder. That's more specific, that the trauma has to be death or threats of death or experiencing actual or threatened serious bodily injury or sexual violence. So this can be experienced by the person directly or indirectly. So witnessing a trauma or even finding out about something traumatic that happened to somebody we care about could also be traumatizing. So characteristics of these kinds of traumatic events is they tend to create certain kinds of feelings, helplessness, terror, intense fear. It's often due to some kind of encounter with violence or death. And the factors that make traumatic experiences more traumatic are listed here. So like being trapped, prolonged exposure to trauma to the point of exhaustion, being caught by surprise, extreme violence, being injured, or witnessing some kind of grotesque death or mutilation. Very shocking. We'll talk about the effects of trauma. So when we think of trauma, we can think about trauma like a distortion or exaggeration of normal human responses to danger. So whenever we encounter something that's threatening to us, we have a natural fight or flight response. So the body releases adrenaline and stress hormones, and the body becomes more aroused, heart rate increases, our mouth goes dry, digestion slows down. So the body is preparing to release a burst of activity to get out of danger. This physiological response also alter perception. So you can get like a tunneling of awareness. So you might hear anecdotes about people who have witnessed a crime or they've been through something very frightening where they can't really remember a lot about what happened, but they may re-zone in on a particular detail. Some aspects, say, of what the person was wearing, but they can't remember like how tall the person was, for example. So there's a kind of hyper-focus that can happen. And this kind of fight or flight state, we can disregard fear or pain in order to respond to the threat. And there's an emotional response to increased arousal in the body tends to correspond to fear and anger. So that kind of response to danger is normal. So if the danger happens, the body prepares to respond, the danger resolves, then the physiological arousal goes away. So when it starts to become traumatic is when that usual response to danger is not enough to cope. If there's no action we can take that will resolve the situation, like we cannot or resist what's happening to us, then the usual coping mechanism is overwhelmed. What can happen is the usual response to danger continues to persist after the threat has passed. And the response persists in an altered, exaggerated state. And there's sort of disintegration that happens with the different aspects of experience. And I'll talk a bit about that and explain what that means. So before I do that, I'll just break down the categories of symptoms in PTSD because I think it's a helpful way of a framework or a way to understand what's happening to somebody who has experienced trauma. So somebody who's diagnosed with post-traumatic stress disorder will have a certain number of symptoms from each of these categories, but somebody who's been through a traumatic experience who doesn't have a diagnosis of PTSD still have some of these symptoms, but not enough to meet the threshold. So the symptom categories more or less correspond to different mind-body systems. So arousal symptoms correspond to physiological symptoms of the body. Intrusions refer to intrusive memories. Avoidance cause a disorder of behavior. And then there's negative emotions and thoughts as well. These symptoms here on the slide of hyperarousal or hyper-reactivity. So it's as though the body has gone into like a permanent state of alert, or the fight or flight response is on, but it doesn't turn off. And this is what I mean when I say lack of integration in the response. So now when somebody's having problematic symptoms of trauma, their bodily experience is not corresponding to what's going on in the world around them. So they may be going through everyday life, everything's safe, nothing dangerous is happening, and yet their body is just pumping out adrenaline. So this includes symptoms like being very jumpy or startling easily, being very irritable or short-tempered, troubles with focus or sleep, vigilance, meaning being always on the lookout, looking all around them for threats. And it can also be self-destructive or reckless behavior because of this hyperarousal. So that was the bodily experience of trauma. There's also traumatic effects on memory as well. And the theory behind this is that the excessive adrenaline that's released during the traumatic experience interferes with the normal encoding of memory. So what happens is the memory event isn't stored the way a normal memory is stored. When going through our lives and we're not experiencing intense danger, then our memories get recorded, and that tends to make sense when we play them back. So there's like a story or a narrative, and things coherently fit together. But in trauma, there's this integrating effect. So the memory isn't stored in a narrative form that makes sense when it's played back. So it can be fragmented. So what can happen is people get intrusive recollections about the trauma. It comes into their mind when they don't want to think about it. It can also come up during sleep. So there's nightmares, and again, these kind of nightmares tend to be just like fragments of memory that keep coming back. Flashbacks refer to a particular kind of intrusion where the person's like dissociated, they're kind of out of touch with the present reality, and they're reliving the trauma like it's happening to them again in the present. And then even if people don't get recollections to that extent, they may still experience some distress after there's a cue that reminds them of the trauma. So either psychological or physiological. An example of this in the population that I work with, a lot of people have come from Vietnam as boat people, and they may have experienced all kinds of horrible things trying to flee the country by boat. So they extreme exposure to the elements, fear of death, being captured by pirates, robbery, rape, murder. They may, say, develop a fear of water, or when they go to the beach, their heart rate increases and they feel very scared. So this is an example of how there can be a reactivating effect of things that are associated with the trauma, but not necessarily intrinsically dangerous in and of themselves. Talked a little bit about the abnormal memory encoding that can be caused by the fear response. Another aspect of intrusions is there be a tendency to reenact or recreate the trauma. People may actually consciously or unconsciously put themselves in situations that are similarly dangerous. So a person who's been assaulted may go, okay, I just got a tip here to please type all of your questions, comments in the chat box and not into the Q&A box. Okay. Sorry. So I think I'm talking about reenactments or creations. So people putting themselves in situations that are reminiscent of previous traumatic events, which would be counterintuitive, but worry is that this might actually be some unconscious attempt to master the traumatic experience. So coming into contact with similar experiences so that the person can have a different outcome or overcome the trauma in a way that they were not able to initially and get some kind of closure. The next aspect about the traumatic experience is avoidance or constriction of behavior. And basically means avoidance of trauma-related thoughts or feelings and avoiding external cues that will bring about these thoughts and feelings. So one of the characteristics about the normal response to trauma is people can swing from streams of hyperactivation, hyperarousal, and being very sort of numb or avoidant and shut down. So whereas most of us are kind of happily living somewhere in the middle, like we're not too excited, too aroused, but we still have some feelings about our life. We're not apathetic. People who've had an extreme response swing from one end to the other. So they can get this extreme distress, intrusions, hyperarousal, and then swinging to the other pole of trying to avoid that and shut down. So the extreme example of avoidance is dissociation. So like going into a trance state or a state where the normal functions of consciousness are altered. And again, there's a non-integrating effect here. So certain kind of memories or certain experiences are separated from ordinary awareness. Okay, so I just got a question. Can you please describe how extreme hyperarousal may be experienced? So I can just go back to this slide. So, typically in PTSD, this is symptoms here being startled, irritable. It's like on edge, having the fight or flight response turned on all the time. Tension, increased heart rate, sweating, being jumpy, irritable. That can interfere with sleep and focus. And the other example we talked a bit about in intrusions. So extremely, the example would be going into a flashback state where the person is actually like reliving the trauma like it's happening to them again in the present. And then all of the like the physiological distress and emotional distress that goes along with that. Yeah, so that's kind of like the opposite of being numb or detached. So dissociation can involve experiences of derealization or depersonalization, where people feel like the reality they're living in is not really doesn't have that sense of realness that we usually have. So people may say like, well, I can hear you talking, but it just sort of sounds like the words are not going in, or they feel disconnected from themselves, like they are observing themselves doing things from outside of their body. Things are happening, but it doesn't feel like it's happening to them. People who have like severe hyperarousal, then the dissociation is the sort of the opposite pole of that. But some people really have the ability to do that, or it doesn't come naturally to them to dissociate or go into a trance state. So that disconnection state may be artificially induced by some kind of escape type activity like taking drugs or alcohol. So the problem with this kind of swinging from pole to pole, or being too aroused and then disconnecting, because doesn't allow for any healing of the experience to happen. Because persons in a very aroused state, they can't really make sense of what has happened to them, and then if they're too disconnected from their experience, it's also not possible to process what has happened and come to terms with it. So you see this endless oscillation between extremes, but nothing can really be resolved. So the negative emotions and cognitions, this is like a new category in DSM-5. In the last edition of the DSM, there wasn't this category. It was just lumped together with avoidance and constriction. But now we're recognizing that negative feelings tend to be part of the traumatic syndrome and not just numbing. So people have feelings like depression, sadness, horror, anger, guilt. Also, those feelings go along with trauma, and there wasn't as much recognition of that before. We would always focus on the fear and avoidance. But it makes sense. Like if you think about trauma as being something that totally overwhelms your worldview and your ability to cope, then it makes sense that you may be angry about what happened, blame other people. You may feel guilty about your inability to cope. It may be horrifying to think about this aspect of the world that you didn't consider in your everyday life. People may go into a state of like extreme negativity about the world, not being able to trust other people, losing interest in things they used to enjoy, feelings of alienation often happen because people can start to feel like the trauma that they experienced is something that's kind of unique to them. Like other people don't have these experiences, they can't relate, so there's something about them that's different and they can't connect to other people anymore. And then the constriction of affect is not being able to experience positive emotions. Sort of like goes on with feeling detached, but like not being able to feel warm feelings towards people or care about people, not being able to have the same loving feelings as they were able to before. Some overlap here with the constriction of experience that we talked about before. So those are the symptoms of PTSD. Uh, People who have a diagnosis of PTSD will have a certain number of symptoms from each category, but again, people who don't have the diagnosis may still have some of those symptoms, and generally the treatment would be similar, which we'll talk about in a bit. I want to talk to you about some of the other experiences of trauma, like not necessarily symptoms. So, a few that we lost sound. I think we're back on again. Okay, good. All right. So somebody asked, how long can somebody have PTSD? I think there's an upper limit to that. We see people in the clinic who have had the symptoms for decades. We see sometimes people after the initial trauma, they have symptoms, like they appear to be functioning very well. But later on in life, the trauma can be reactivated by something else traumatic that happens, or some other life challenge, stressor. So an example might be somebody who's like one of the people who had the trauma from war, Vietnam, comes to Canada, seems to be fine, but 20 years later they get into a car accident, and then after that they start to become depressed, and the PTSD symptoms start. So just to say, the traumatic symptoms don't necessarily have to start immediately after the trauma, and yeah, they can persist for a very long time. I think before that I was talking about the aspect of trauma. So not all of us are going to experience having our life threatened, or being death, or witnessing somebody being a victim of violence. But we probably will experience something that challenges our usual ways of coping. And my view is that we respond to those minor traumas in a very similar way to the major traumas. Like, to say that we all develop PTSD. Some people do, some people don't, even with major trauma. But we need to still go through the same process of trying to integrate that experience. Trying to understand does trauma affect people? Why do some people get PTSD and some people don't? Think about vulnerability and resilience factors. So some factors related to the person and also related to the trauma will make people more likely to have a bad experience. And there are some factors that make it more likely that they'll be able to get through it, integrate the experience, and move with their lives. One of the points that Judith Herman makes in her book about trauma is, everybody's immune to trauma. So if you have enough of it for a long enough time, most resilient people will be overcome. And we talked about some of those factors earlier on. So being surprised, repeated trauma, trauma to the point of exhaustion, extreme violence. So having multiple of those kind of factors over a period of time is more likely to lead to symptoms. The factors that are related to the person that predispose them to trauma are like basically somebody who's like the self is not well established prior to the trauma. They're not functioning well as a person before they're traumatized. So they don't have the resources to get through it. So populations that are already disempowered or disadvantaged, people who already had a mental illness like an addiction or depression before trauma are less likely to be able to cope. People who are younger as well, like they just haven't had the time to learn how to cope with stress, so they're more vulnerable too. And the part about participating in atrocities, that's more applicable to the war scenario, but people, they found that veterans who participated in like revenge type atrocities in the context of war were more likely to have symptoms of PTSD than those who didn't. The protective factors are in many ways sort of the opposite of the vulnerability factors. So people who are functioning already, meaning they get along with people well, they cooperate with people, they have an active coping style, an internal locus of control, meaning they see themselves as being able to control what happens in their lives through the things that they do. Those people are more likely to be able to mount an effective response to the traumatic experience and feel like they were able to get through it. So let's one example in the context of women who are raped or sexually assaulted. Been an observation that the women who are able to resist or fight back are less likely to experience traumatic symptoms afterwards compared to the ones who go numb or are not able to resist. And that's likely because they feel more empowered after, or they feel like they did everything that they could do. So they're less likely to be prone to feelings of guilt or shame. One of the important points about trauma too is that there's experience of trauma and recovering from trauma a lot on relationships. So trauma doesn't happen to an isolated person that lives in a vacuum. Like it always happens to a person who lives in a community and a family and a society. And that person's relationship to their community will affect how they cope with the trauma. So in the last slide, when we look at the vulnerability factors, like people who are already disempowered, disconnected, who can't connect well with other people are more vulnerable to the effects of trauma. Already has an undermining effect on people's sense of self, safety, their ability to trust in the world. As I mentioned before, people who experience trauma are more likely to feel alone or abandoned or isolated. One, they might feel like other people don't understand the experience they've had, but also because when they were going through the trauma, there wasn't help available. People weren't able to change the outcome. That all compromises the sense of safety and connection. And one of the ways that this plays out is you can see either extreme of like really clinging to people and not wanting to be alone, or feeling very cut off and isolated. Trauma also affects the sense of self. So when we talk about developmental conflicts, this refers to a developmental model of personal growth. So starting from childhood and going throughout life, different kinds of stages or transitions that people need to navigate through. So from learning to be autonomous and having trust in the world and self-confidence and feeling as though you can do things effectively to change your life, all the way through to later in adolescence, establishing a sense of identity, closeness to other people. Those normal stages that everybody needs to go through. If one of those stages hasn't really been navigated that successfully, okay, I think the sound's back again. I don't know how long we were out. Is it working again? Still getting some comments that say no sound. Okay, sound's back. All right, so he might have cut out at the part about superstition. That was more of an interesting anecdote, really. But you can see that sometimes in people who are going through trauma that they believe that they're not in control of what happens to them, and they may be superstitious, carrying lucky charms, or believing in superstitious rituals. It kind of becomes a source of comfort. And so people who already have a better sense of confidence before they experience the trauma are less likely to go through this kind of experience because they already have an active coping style. Yeah, on this slide, the 2,000-yard stare or the shock look refers to the dissociation that can happen with trauma, where you see it in the photos of the soldiers, this kind of glassy, dazed look, like they're there, but they're not really there. There's in their mind, they're disconnected from what's happening to them. So it's just a powerful image to remember that. So we talked about how trauma affects the experience of relationship, how it affects the sense of self. There's also an effect on our sense of the world. So encountering trauma, particularly when it's administered by other humans, it's the encounter with evil. Like I mentioned before, most of us go about our lives believing that people are fair or good, we're safe, kind of order in the world, and go through something violent really make you question that. So, for example, if you've been assaulted and robbed, like you now have this experience that says, well, okay, maybe before I believed that people would respect my body and my physical space, but now I see that that's not necessarily the case. That can be compromised. Other people can do evil things to me. Depending on the context of the trauma, people may have to deal with other I guess you could say confrontations with reality, like maybe in order to survive, they had to abandon somebody else. So they need to come to terms with their own ability to do that, because that sort of behavior usually doesn't jive with the way we like to see ourselves. So as a result of these experiences, you can get depression, anger, shame. How trauma can affect our worldview, necessarily on a symptom level, but just how it affects the way we think about our lives. So the last couple parts of this talk, I'll be going over how to help or support somebody with who's experienced trauma. So this upcoming section talks more about like the community or family level. So not necessarily like you're the person's therapist or their doctor providing treatment, but just like what do people around the person need to do to be helpful. And after that, I'll talk about the clinic setting. So what does the therapy or treatment for PTSD look like? The community family type interventions apply to somebody who has a diagnosis of PTSD, but also somebody who's just experienced trauma. So the general principles are to restore a sense of connection to other people, support positive views of self, and restoring the sense of empowerment or control. And this really directly links back to the discussion before about the effects of trauma, which disrupt all of these things. So we talked about how trauma affects the sense of connection or community. So the response to trauma really has to counteract that. So that may mean just being there for the person and ensuring them that they are safe and that they won't be abandoned. So I remember one of my supervisors in residency talking about this, like when somebody has just come through a traumatic experience and they're in the emergency room, like you don't need to debrief them about the trauma or interview them or like ask them about what they went through, but like you give them a blanket and sit with them, and that may be very helpful just itself, because in that moment they just need to have that safe environment. When we talk about rebuilding a positive sense of self, the person has gone through an experience that really challenges their sense of being able to defend themselves, influence the world around them, and act effectively on the environment. So they're going to need to reestablish a sense of being able to do that. One of the principles I've put here was to realistic judgments or realistic appraisal of what's happened. And actually, these slides, I think I changed them, but the changes didn't actually make it into the presentation. This applies to family, friends, but I think it also applies to care providers that the person may see after. In my change slides, I said we need to bear witness to what happened and try to suspend our preconceived judgments. So what I mean by that is we don't want to go to each extreme of hard criticism or blind acceptance. Former refers to blaming the person for what happened, or saying okay, well, if you just did this, or you didn't go there, or you didn't wear this, then this wouldn't have happened to you. That's a way to make ourselves feel better, to make the other person different from us. So it happened to us because we didn't do the same thing that they did. One of the writers I've read called a talisman. It's a sort of lucky charm or a magical thing that we can hold on to make ourselves feel better, but it's not helpful to the other person. But the other extreme of that is the blind acceptance. If then is having some serious doubts, okay, well, maybe I should have done things this way, or maybe I had an opportunity to escape, but I was paralyzed. To recognize that there are limitations and serious constraints to the situation, but there was something that they can learn from the experience, or that they might be able to do better, then if we acknowledge that, that can actually be more empowering to them, because they can feel okay, at least I learned from this, and maybe next time this is not going to happen the same way. So we don't want to fall into that extreme of giving a pat response, oh, it's your fault, there was nothing you could do. I may say that, but we don't want to take it to the extreme that we're basically giving them the message you had no control over what happens to you, because that's actually disempowering. And the other point that I put on the modified slide that's not on here is another lesson I learned from a supervisor, that we call things as they are. This was the context of a trip up north and doing psychiatric consults with a native population, and I had seen a teenage girl who was raped and used kind of other language. She didn't call it a rape. She it was made have sex against her will or something like that, but it was euphemistic. And so I repeated this back when I was summarizing the case. He called me out on it, and he said, no, if this person was raped, we have to say that it was a rape, because that's what really happened, and that's what the person is dealing with. And if we sort of minimize that or try to sweep it away, again, maybe that makes us feel more comfortable, but it's not necessarily helpful for them. If somebody did something wrong, or they committed a crime, or they violated somebody, like, that's important to recognize. So I think the things that are on this slide I talked about. So just, again, maintaining that balance, like recognizing that the person's options were limited, and they did the best they could under the circumstances. But if that's something that they would have liked to do better, like, we may have to acknowledge that as well. And leads into the point of empowerment. Really, that's an essential principle, I think, to consider when supporting somebody who's been through trauma or treating trauma. Think about, this thing that I want to do, or this thing that I want to say, is this restoring power to the person, or is it actually taking it away? And if you keep that in mind, I think it will guide you through making the sorts of decisions that I just talked about in terms of maintaining that balance. So if a crime happened and we don't call it a crime, maybe it's disempowering to the person because it doesn't really recognize what happened. But it tells them that they were powerless to do anything, and there's nothing they could do differently next time. That can be disempowering too, because away the sense that they can learn from this, or they can do anything to protect themselves next time. So the community recognition of trauma, again, to that principle, that trauma doesn't happen to a person in a vacuum. It happens to somebody who lives in a community, and the recovery from trauma also takes place in the context of a community. So we can, recognizing a trauma has happened and taking some kind of public restorative or reparative action helps to give a person back a sense of meaning, that other people are going to be there for them, that our society is sort of coherent, there's some kind of order, it's not just total chaos. And one of the examples, it's the war context that comes to mind. Read about the Vietnam veterans' experience of coming back to their country and having been through traumatic experiences, being horrible trauma, and perhaps even participating in some of that trauma themselves, and then their society does not recognize them, does not acknowledge them, does not want to talk about it, that it wasn't actually like a real war, is really, really disempowering and very isolating. So you can read about just having the Vietnam War Memorial being erected gives people something that they can organize their experience around, like, okay, this actually happened to me, and it happened to other people who are in a similar situation, and some recognition of this in my society. So I mean to make this really like a political talk or anything, but I think this is important when we're thinking about the community response, to keep this in mind. Like, we can't keep trauma under the rug, because the people who have experienced trauma will continue to suffer. So in Judith Herman's book, Trauma and Recovery, she talks about the male experience of war as being like the prototypical male trauma, and for women, sexual assault, rape, domestic violence. And so it's an analogy there that there's something we need to recognize, and there's an important role for the justice system to recognize what has happened and take some kind of reparative action so that the person who's experienced the trauma can sort of have their faith in society restored. Important point about helping people through trauma is that the people who are helping also need help themselves. Again, like the person recovering from trauma does so in the context of a community. Part of that community is the people who are supporting them, but those supporters also belong to a community and they need support as well. You can say trauma is contagious. So you sit and you listen to trauma and you hear about the horrible things that have happened to other people. Like, it has to go somewhere. It is in your mind and it affects you emotionally. I can tell you this from experience, just working in a acute clinic where, you know, I was seeing like week after week, like people would come in, like young women, talking about how they've been raped, assaulted, or they were still in danger, and dealing with patients who were committing suicide. Like, to see a lot of these traumatic experiences like starting to come up in myself, like including the magical thinking, the passivity, looking for lucky charms, feeling like I couldn't do anything really to help these people or change the situation. So I did the anecdote about the Ace of Spades because this is something like I could see myself going through. In terms of communities or institutions, we really need to make sure that the people who are dealing like with the clients or the patients, like the frontline workers, also have support for themselves. We're working with trauma, like we can start to feel overwhelmed or isolated, or our colleagues or our peers or our families are not going to understand like this sort of world that we're living in. So the problems that can come from that is identify too much patients, and as I mentioned, like we may start to feel hopeless and helpless, or we may identify with their anger or their rage, and then we may want to act out on like acting against our superiors or the institutions, expressing our anger in an unhealthy way. So I just a request to repeat the 200 stare, or the 2,000 yard stare. So the picture is here. I mentioned before this. These kinds of images capture the dissociation that can happen with trauma, being so overwhelmed that the person like disconnects from what's going on around them. And there's been many examples of this throughout history, different wars. I think this particular example is World War II illustration. There's been another famous one recently, I think the Marlboro soldier, named after the cigarettes he's smoking, but I think that that's in the context of Afghanistan. Again, like the same kind of dazed, glossy expression. overshot. Okay, right. So supporters need support. So I've just listed some of the pitfalls here and talked about some of them. It can be a narcissistic desire to rescue the person or a narcissistic way of coping. Just means we identify with a sense of grandiosity in order to help us cope with what's happening. We identify with this fantasy that we can cure everybody, that we, like our love for the patient, will be able to fix everything, or that we know everything, and that can make us ignore our limitations. And then there's also be a guilt effect of dealing with so much trauma that we actually start to not be able to enjoy our own lives because there's sort of vicarious survivor guilt, and it can lead to overwork as well. So that's important to just to keep in mind, and particularly. About the trauma being contagious. If the worker, the supporter, has also been through trauma, then hearing about like the trauma can reactivate the traumatic memories of the people who are trying to support the person. And this doesn't necessarily have to be like you've been through a PTSD level trauma, but we all carry around some of this type of thing with us. I believe like it's even transmitted from ancestors or from our family members. So if like our parents have been through something traumatic, we inherit the stories or the memories, and that can become reactivated by about somebody else's trauma. I'll just mention that a bit because it may be relevant to somebody, and it may be helpful to make sense of something you might encounter in the future. One it was put to me was one of the supervisors I worked with was of Jewish background, and he spoke about parents living through the Holocaust, but him not saying that directly, but he remembered like this intense experience of fear when he was on a train in Germany, and the police on the train with the German shepherds. So this was a person like no experience directly of concentration camps, but something about the dog activated some kind of memory that was somewhere in the unconscious. So it seemed like a little bit hard to understand, like how can you remember something that you didn't experience directly? There may be something about how our parents are with us, the kinds of things they tell us. There'd be some act of it that's encoded epigenetically, that's actually transmitted to us in our genes. So mechanism may be more clear in the future, but there is this phenomenon that you may carry something around with you even if you haven't experienced it directly. So I don't know if anybody's noted that, but you might encounter it. It's happened with me before too, so maybe knowing about this in advance, like it won't be perplexing if it happens. So this is an important slide, I think, talking about integrity. So a lot of points during the talk I've Okay, sounds back. Okay, yeah. Okay, so okay, let me come back to the integration part, just to um, uh, answer this question about aggressive behavior. Um, so yeah, the reason why, like, understanding, but we don't want to answer or tolerate too much aggression is because we don't want the person to become further traumatized. So the where this might happen is, like, if somebody who's been through trauma, they're very irritable, very angry, and like they're being physically violent towards others, or they're being very verbally abusive with their family. Like, it doesn't feel good for the person to be doing this either. And I mentioned before, like in the context of war, the veterans who participate in atrocities, like who retaliate, who kill civilians or kill prisoners, those people are actually more likely to be traumatized compared to the people who don't. So, like, you're acting out and we're making the people around us feel bad, we're hurting them, that hurts us as well. That doesn't feel good. And it can add to the sense of shame and being out of control. So, validate that we can understand how the person's feeling, or maybe ask them how they're feeling. But then we may need to set some boundaries or some limits and explain, like, this is good for you. It's not healthy for the therapy for you to, like, be yelling at me like this, or calling me names, because I feel scared and I can't help you if I'm scared. So could we be like, can we take a break, or can we tone it down a notch, or can we maybe pause here and do some breathing exercises just to take the level of emotion down a notch, for example. So I'll talk a bit more about these skills that we can use to modulate arousal in the moment when I talk about treatment. But yeah, I think I have maybe 20 minutes left, and there's just a couple sections, so I don't want to get too bogged down. So I have some time for questions too. Okay, so we're back to integrity, and how integrity relates to healing from trauma. So the connotation of integrity is sort of like being whole again. And when I talk about the symptoms of trauma, there's a real element of fragmentation or disintegration, like the different parts of our experience don't add up or correspond to each other. So we have, like, out of control memory, or we have the fight or flight response when there's nothing to react to, or not feeling happy when the circumstances around us are happy. So becoming whole again means that they are healed, that our memories have a place, and they're not sort of these isolated fragments that are just popping up with no context. So trauma sort of or goes counter to our usual model of thinking about the world. You can think about trauma as being some kind of experience that doesn't fit the mold. It's like a puzzle piece that doesn't fit in with the rest of the puzzle. And we have to find some way to alter the framework so that trauma fits in a way that makes sense. So finding integrity again means we come to terms with what happened to us. being able to accept what happened, accepting the experience, accepting our limitations, accepting our mortality, but then finding some way where it is compatible with living life. So we have to connect with a sense of meaning, that even though I'm fragile, I'm mortal, I can be harmed, I bleed, still something good and meaningful about my life. So when I said integrity is the means and the end, it ends in the sense that this healing from trauma looks like. But how we heal is finding this integrity. And I think when we're supporting people who have been through trauma, our integrity allows other people to trust us, meaning in some way to come to terms with our own limitations, our mortality, the experiences that we've had. And since we're sort of more or less okay with life, people feel comfortable with us, and that allows us to work with them. So Mark Epstein talks about this in his book, The Trauma of Everyday Life. I think it's a great book. I recommend it, but you can think about trauma as actually being a necessary part of life, that being confronted with our mortality, our fragility, that's really just being confronted with the truth. And if you can find a way to incorporate more of the truth into our model of understanding the world, then the way we live corresponds more closely to reality, which is, I mean, you could call that personal growth, maturity, spiritual development. There's, something, I guess you could say, about trauma if we use it in the right way. Okay, so the last section here is treatment trauma. This is more the clinical perspective. So one of the things we found is debriefly after trauma are not particularly helpful, maybe harmful. So that means, like, when people have been through trauma, we more just support them, let them be in the community, see what happens. We don't kind of pull them out and make them sit in a group and then talk about their experience of trauma to try to prevent symptoms from developing, because maybe being in that situation, hearing about how bad it was for everybody else might actually be more traumatizing. So we wait, see if they have more is beyond the sort of general supportive stuff I talked about just now. Then we need to treat them. So the treat for trauma, I've found helpful to Judith Herman's stage model of trauma. Stage 1 being establishing a sense of safety. Stage 2, she calls it remembrance and mourning. You also call this like processing work, processing the trauma and integrating it. And then stage 3 is moving on, like getting on with your life, which that's really the end goal. Getting back to normal functioning. So this is a model for therapy trauma, but I think the medication treatment of trauma also can be incorporated into this model. So you could think of it as a treatment, not just psychotherapy. So one, safety. Much of principles we covered in the community and family and friends response to trauma. The realistic perspective, bearing witness, naming the trauma, sort of being with what happened, helping the person to restore a sense of control and safety. This is really the foundation for the processing work to happen. So if there's no safety, you can't do the treatment. Like, sense to talk to somebody about the past trauma if they're still being traumatized in the present, because they're in no state of mind to be able to make use of that. So when we talk about safety, we mean like physical safety, safety of the environment, having a place to live. But it goes beyond that to having some kind of stability in life, to have a routine, to have other things to do, and also we want to try to help people be free from drugs and alcohol, so they're not going continuously into this numbing state, and have empowerment over the basic aspects of their life, like their financial situation, their health care. And this relates back to having a sense of empowerment. So we talked about safety, basic health needs, regulation of routine, bodily functions, eating, sleeping. I think also it's important to be connected to other people, have other things to do. When I was a resident, I saw who came into the emergency room who had PTSD and was in active treatment, but she was decompensating and her symptoms were actually getting worse as she was talking more about the trauma, because she didn't have anything else going on in her life. Like, she wasn't working, she wasn't seeing friends. So it was like her whole life just revolved around going to therapy and talking about the trauma. And if it becomes like so consuming like that, people can get worse instead of better. So it's actually helpful to have something else they can do, and just, a little bit of work on the trauma, put it away, do something different, think about something different, just maintain a sense of balance. Stage 1 of trauma also is where we can think about using medications or specific techniques for controlling certain symptoms. They're too intense. So I have a slide coming up about medications. In terms of specific techniques, this refers back to the question, say, about aggressive behavior, acting out, feelings that are too intense. The person may be self-harming, for example, cutting themselves, binge eating, drinking, getting into fights. There's so much of this negative emotion is just spilling over. So here, we don't want to talk more about trauma. We want to actually give them skills to help them manage how they're feeling. The skills from dialectical behavior therapy, where this, for those of you who don't know, is like a form of therapy to treat people who have extreme suicidal or self-destructive behavior. So we can use skills from that model to help people self-destruction from trauma. And a lot of DBT focuses on building capacity to tolerate emotions or distract themselves in a healthy way until the emotion passes. So I have a couple of resources here. The Healing Power of the Breath is a short book by a couple of American psychiatrists, and it talks about using deep breathing techniques, most from yoga. They also incorporate a bit from Tai Chi or martial arts, but the idea is slowing down the breath slows down the body, decreases the physiological arousal, helps promote a relaxation response. So when somebody is so anxious they can't sleep, they can't think, they're on edge all the time, they're tense, these techniques can be quite helpful. They've actually gone and used these techniques for people who have survived natural disasters right in the aftermath of trauma, where people just need to be able to calm down and feel safe. So very simple techniques, like one that you can do with somebody, just box breathing. Breathe in for 4 counts, hold your breath for 4, breathe out slowly and smoothly for 4 counts, hold your breath out for 4 counts, and just keep repeating that. Just slowing down the breathing that way uses a relaxation response, and that can be quite powerful. The Dialectical Behavior Therapy Skills Workbook is a good resource too for distraction techniques. So when somebody is feeling overwhelmed and they're tempted to do something that's going to make things worse for them, like they're going to cut themselves, they're going to reach for a drink, then we want to teach them something they can do instead until the feeling passes, so they're not adding fuel onto fire. Examples of this might be, instead of cutting yourself, get an ice cube, hold it in your hand, focus on the physical sensation. Another one that my patients find helpful is like fill up a sink with cold water, maybe put some ice in it, take a deep breath in, hold your breath, and put your face in the water. Hold breath as long as you can, and then exhale slowly. So you've got like a multiple direction effect here. Like you get the distraction from the cold water. You also get the diving response from holding the breath and cooling the face. That physiologically slows down the body. And then mentally you can focus on the sensation, so you don't keep thinking about whatever it is that's bothering you. So if you're interested, you need some specific techniques, I would recommend checking out these 2 books. So I'll talk brief medication. I don't think we have physicians in the audience, so I'm not going to talk about like specific medications and dosing and side effects and all of that, but just it may be helpful to have a general sense of what people may be taking and why and what it does. So in general, we use serotonin reuptake inhibitor antidepressants to treat the anxiety symptoms of PTSD. So this includes like Prozac, Zoloft, Paxil, Effexor. Just these are some brand names of medications that people may be taking. The whole idea with these medications is they dampen down those strong feelings. So people will say, like, stuff just doesn't bother me as much as it used to when I'm on this medication. Antipsychotic medications like risperidone, quetiapine, or Seroquel, this also has a similar kind of dampening down effect. Generally, I try to be careful with antipsychotics as they have more side effects than antidepressants, and the medication can make people kind of too like blah or apathetic. So, but sometimes for people who have really like a lot of intrusions and hyperarousal, they can be helpful. Also, they might help with sleep. Persin is a specific medication usually used to treat high blood pressure, but for people who have intense nightmares, sometimes it works like real. give them Azicin. They can now sleep. They're not afraid to go to sleep because they don't have as many nightmares. And then once they're able to rest, their mood is better. They're able to focus better. They have more energy. So that can be a helpful option as well. So moving on to the safety stage, once somebody is in a place where like they're reconnected to their society, they have some supports, they have things that they can do in the day to distract themselves. Their symptoms, if they were really intense, are a bit more manageable with medication. Now we start to do the integration work. And this is the part where people start to talk about the trauma, and tell the story of the trauma helps them to experience emotions that might have been cut off or dissociated before. And going this process is like taking the pieces and fitting them together into something that makes sense. So instead of having the same intrusive memory fragment that's bothering them over and over and over, they can now tell a story like, okay, this is what I was doing that day, this is what happened to me, this is how I felt, this has been the after effect, this is what I can do about it. So it becomes like a regular narrative memory. So it makes sense and it doesn't have to keep coming up over and over. So that's really what we mean by integration. And I mentioned it before, and I'll say it again. Like, it's very important to do this kind of work at the right time, because if you do it prematurely, before the person has a sense of safety established, before they know how to deal with strong emotions, it will be re-traumatizing to them. They may decompensate. And you try to do this kind of work when there's already a different crisis, they're dealing with something else very emotional. It may just be overwhelming and just too much. So we need to be careful to do it at the right time. And we may not guess for months or even years, like depending on like how often we can see the person in the context of their life. You may spend most of your time working with somebody just in stage one, like helping them to function a bit better and manage their symptoms. So we really have to tailor the treatment to the person and not be too gung-ho and just rush ahead. So the one way of thinking about this work is forming a coherent memory. Another aspect of the integration work that may explain what's going on is just pure exposure therapy. The idea being, like, for any type of anxiety disorder, if you expose the person to whatever makes them anxious and they can learn that that experience is safe, their anxiety will go down. So if you get the person to write down a narrative of their trauma and just read it back to themselves repeatedly, like day after day, like for half an hour every day, like 5 or 6 days a week, their anxiety level initially goes up. When they start reading, that starts to go down. And if they stop the exercise after the anxiety has gone back down, then they start to learn that, okay, thinking about the trauma is actually safe. Like, nothing dangerous happens to me. I'm just reading words on paper and remembering something. So this is a memory. This is not the actual experience happening again. And just from pure exposure to the anxiety over and over, they may habituate, or they'll be less sensitive to the anxiety cues in the future. So we might do this with reading a script about the trauma. It might be going somewhere that reminds them of the trauma. It might be looking at a picture that reminds them of what happened. just try to desensitize them that way. So there's an aspect of the retelling that deals with anxiety, but also there are emotions that go along with trauma, not just anxiety. So the sadness, the anger, the shame, and that also can get better with talking about the trauma, but it may be a different process. It's not so much exposure therapy as it is mourning or grieving. So we do this with challenges that we go through in life, loss being the main, but there's a similar effect that happens in trauma too, I think, and similar stages like finally being able to accept what happened, letting go of denial, letting go of our anger, the feelings, feeling the sadness, feeling the loss of like the life we used to have, the beliefs we used to hold on to, and then forming a new view of the world. So Judith Herman talks about barrier to mourning being like fantasies of revenge, compensation, premature forgiveness. So what she means is people get stuck in mourning. So instead of mourning and accepting and moving on, they get stuck on like seeking revenge for what happened, and they just ruminate over and over and over about their anger and their rage, and that prevents them from being able to move on. Seeking compensation, meaning like holding on to this idea that somebody is going to come in and make things right and undo what happened. And if holding on to this fantasy of something that's not going to happen, that's never going to happen, can't accept what happened and go on with life. And this is not just with trauma, but people dealing with disappointments in their life, people letting them down. If they keep thinking about like, okay, I'm going to get what's mine, I'm going to make them pay, they're going to compensate me for the years that I lost, they never move on until they let go of that. And then premature forgiveness means like jumping to a fake forgiveness, like it's fine, I've let it go, I'm past this, I've moved on, when you haven't actually done the difficult work of like feeling the difficult feelings and feeling the grief. So you can't skip over this, basically is what it means. And then the third stage, reconnection, is that slide about integrity. This is like dwelling in integrity again. So having new relationships, a new sense of self that you can live with, having new goals, feel empowered again, have a sense of something you want to contribute to the world or something you want to do. Basically having a sense of meaning again. Once you go through the remembering process, processing, you go through the mourning and the sound is back. Okay, so this was last slide, I believe, so I can get questions that you have now. I've got one here. You spoke about a pendulum of range of emotions. Can you explain? So what it means is alternating between extremes of very strong, overwhelming emotion, and then going into a state of disconnection, dissociation. If we go back to the symptoms of post-traumatic stress disorder, on one hand, you get this hyperactivation, just being very anxious, on edge, angry, and then the other strong emotions we talked about later that are not part of the PTSD, but having a lot of anger, shame, guilt. People can be overwhelmed by this, and then they swing opposite, which is just being numb, disconnected, or artificially numbing themselves by distracting, consuming things, drugs, alcohol, and basically being anesthetized. So it can happen deliberately, like people may take something on purpose, but they may just go into a state of dissociation or numbing, like spontaneously. It's not always under their control. So I think we have more time for questions, if there are any. I don't see a window, so I may just maybe give a minute or so. Okay. So if there's no questions, we can wrap it up here. So thanks for your attention and your questions. I hope you get something out of it that you can use directly to help people, or maybe even help yourself in the what you do. So for your efforts, thanks to Maria and Emily and Dad at Hong Fook for helping to put this talk on. Just mention again about this survey. Hopefully it's popping up soon, and you please complete it. The feedback's very helpful for us to know what to focus on in the future. And there's a question: can they get a copy of the PowerPoint? Okay. So the ladies will email it out. I'm happy to distribute it. Okay, great. Thank you. Bye.